Right, so my name is Victor Dabel. I'm OBGYN physician. I am based in Denver with consultants in OBGYN at Presbyterian St. Luke's. I started to come here to the Kit Carson Memorial Hospital in Burlington in 2010. Started this OBGYN specialty clinic. There were a few changes recently, so I want to talk a little bit about that and a few ideas for the future. In terms of the programs that we can do here is obstetrical care and gynecology. For obstetrical care in the past, as you all know, there was a possibility to do deliveries here at the hospital with Dr. Hoppy, Perez, Pimentel, Giti2. That's not an option any longer, so it's a little bit more work to be done, and these patients will come for delivery. They will come to Denver, to Presbyterian St. Luke's. The good part after those changes was that the nurse practitioners and physicians and all the providers here agreed to continue to do prenatal care. I come here once a month. I have two other partners. They used to come to Burlington as well, but they are not coming any longer. So at this time we have 1 day a month. Most of the care for OB patients can be done here, so it starts with initial visits. Providers will order the ultrasounds for confirmation of pregnancy to be done here at the hospital. Blood work for the prenatal panel, and then usually we try to get involved in the second trimester. At that time, the patients will schedule a visit with me here. This way we can get all the ultrasound reports, blood work, history and physical, due date, and establish the care with us and have everything in our electronic medical records in our system. This way, if there is a problem, a complication, need for the patient that the patient needs to go to Denver, we do have all the information, results, ultrasound, and everything. Once we establish care with the patients here, then we are available over the phone as well, or emergencies, so the patients can call our clinic in Denver. One of us is on call all the time, and if there is a need, patients will come to Presbyterian St. Luke's. Most of the times it starts with an evaluation here in the emergency room, and then the PAs from the emergency room will call, and then we decide together if there is a need for the patient to come to Denver, if there is an emergency, if they need to call an ambulance or even the helicopter for the transports. For all these patients, we can also evaluate them in Denver at our clinic, consultants in OBGYN, and also we work with the high-risk OB group called OBX. They have a high-risk OB, maternal fetal medicine specialist, on call all the time. During day, one of them is in the hospital at PSL, so it's quite easy to work with them. So certain things that we can continue to do here at the hospital is the confirmation of the pregnancy, the first ultrasound, the 20 weeks ultrasound scan, and also we can, for patients having complications like high blood pressure, diabetes, or any other obstetrical problems, if we need to do biophysical profiles, those can be done here in radiology. Either the providers from the clinic here can put the orders, or I can put the orders. We can also do non-stress tests, meaning put the baby on the monitor on labor and delivery. Then usually from labor and delivery, they fax me the strips look at them and decide if we need to do anything else or it's safe just to follow up. Again, once a month we'll be here for the specialty clinic. In the past, for genetic screening for pregnancies, we used to do the first trimester screening. That was blood work, screening blood work for genetic anomalies and an ultrasound. For the last couple of years, we have the option of non-invasive prenatal testing, or NIPT. This is a test where the blood, the patient's, the mother's blood is sent to the lab. The lab will isolate fetal DNA from the maternal blood, look at the chromosomes and tell us if there are any chromosomal anomalies. It's a very, very good test, and this way patients don't have to come to Denver, see a high-risk OB doctor for the first trimester screening. For the future, we are working on developing a little bit more the programs for with televisits, either for myself or for the high-risk OB. Patients with any type of complications during pregnancy, like diabetes, high blood pressure, preeclampsia, usually they need a consultation with a high-risk OB. So it's still in progress, still in the works, but what we are trying to do is to have the option of a televisit. The patient will be here at the hospital in one of the rooms that were specially done for televisits, and on the other hand, one of the MFM doctors will be live with the patient from their location in the office in Denver. This will avoid a long trip back and forth to Denver, easier ways to do the consults, and getting the results faster. One other item that we are working on is to have those OB ultrasounds that we ask the high-risk OB doctors to do. One option that we were looking at was to have a camera in the ultrasound room downstairs at the hospital, and the high-risk OB doctor will be able to look on the monitor. That is not very accurate. The other option is to upload all those images on PACS or another cloud-based system. And after that, the high-risk OB can pull those images, look at the images, do measurements, and give us a report. The only problem with that option that's way more accurate is that if the ultrasound tech will not get the right images, then we need to repeat the ultrasound. So the way it works at this time is the tech will get the images, upload them on PACS, the patient will leave, and the other doctor will look at those images. So if there is a need to repeat something, patient needs to come back. So we are working on those options. Hopefully we'll find a good way. This is pretty much in regards to OB care. For GYN, we do consults here. I'm available all the time for the physicians and nurse practitioners if they have questions for me, and then I can see patients here. So in general, we do consults for bleeding abnormalities, look at ultrasound results that are ordered by the other providers, biopsies, patients with pelvic pain and endometriosis, polyps, endometrial hyperplasia, fibroids, ovarian cysts, and menopausal issues, in consultation with the providers that are taking care of patients here for hormonal replacement therapy, or those patients doing hormonal replacement if they have any abnormal bleeding, they need a follow-up, or occasionally an endometrial biopsy to rule out hyperplasia. Things that we can do here at our hospital here at Kit Carson Memorial Hospital are laparoscopies, diagnostics, sometimes ovarian cysts or tubal ligations or salpingectomies for permanent sterilization. Hysteroscopies remove polyps, fibroids, or occasionally foreign bodies like an embedded IUD. I'm looking for developing a little bit more the options for surgeries here, and I think a very good option would be to do laparoscopic radiofrequency ablation for fibroids, and we'll talk a little bit more about that, and endometrial ablations for abnormal uterine bleeding. So again, we can do consoles, biopsies, colposcopies for abnormal paps, interpretation of the labs, and consoles for infertility as well. Some of these patients have to come to Denver if there is a need for a more complex surgery, like robotic hysterectomies, complex myomectomies. At this time, laparoscopic radiofrequency ablation, I do it only in Denver. Hysteroscopies if they are more complicated, or complicated cases for endometriosis, or combined surgeries. Occasionally we have patients that will have a hernia that needs to be repaired at the time of hysterectomy or a cholecystectomy, so we can do those combined cases at PSL. In terms of most common problems that we see patients for the GYN clinic are abnormal bleeding, pelvic pain, pelvic pressure, related mostly to uterine fibroids or other abnormalities. Patients coming complaining of any of these symptoms, they can either see their own provider here, or I can see them, and the next step is to do imaging. All the imaging can be done here. Ultrasound, saline infusion, sonography, hysteroscopies, we do them in the operating room here with general anesthesia, MRI, and CT scans. Occasionally, patients will end up in the emergency room here because of acute problems, mostly related to abnormal bleeding, heavy bleeding, hemorrhages, or acute pelvic pain with the rupture of ovarian cyst, an ovarian torsion, or acute pain. So after the patient is evaluated in the emergency room, imaging is done. Usually the PA will call us, and then together we'll make a plan, see if we can do an elective visit, or if the situation is that the patient needs to be transferred, then patients will come to ESL in Denver. Treatment for abnormal bleeding and fibroids, we try to do the management of the symptoms, and the second step would be to do management of the fibroids if the patient has fibroids. First part in general is done by the providers here, the primary care and nurse practitioners, in collaboration with us as well, to establish a treatment, and then we take over for surgery. Again, some of the surgeries can be done here, submucosal myomas, endometrial ablations. Other patients need to come to Denver for treatment. These are a few options for acute management. Some of these options can be offered here in Burlington. Some, if the hemorrhage is severe, need to come to Denver. But IV estrogens, tranexamic acid, something to temporize or get control on the bleeding until the patient is transported to Denver. If there is an acute hemorrhage, occasionally we need to do a hysteroscopy, a myomectomy, use interventional radiology, or do surgery, even an emergency hysterectomy. A few of these procedures, we can do them here. One of them is the endometrial ablation. I did have a few patients, not recently, but in the past that we did endometrial ablations here. The device that we use is NovaSure. Endometrium has two layers. One is superficial that comes out every month when with a menstrual cycle, and the deep layer will regenerate every month. With a device and deploying radiofrequency, if we destroy the deep layer, then endometrium is not regenerated any longer. It's, I would say, a quick procedure. It takes only a couple of minutes, done with general anesthesia here. Patients would go home probably an hour after the procedure. By the next day, they are back to their routine. This is indicated for heavy menstrual bleeding. About 50% of patients having an endometrial ablation have no more bleeding whatsoever. Up to 90% there will be a significant improvement in the blood flow, meaning they still have a little bit of spotting once a month, but nothing compared to the bleeding before the ablation. It is a safe procedure, and again, I think this is very appropriate for treatment to be done here. Hysteroscopic myomectomies, we use the MyoSure from Hologic. We have the hysteroscopic camera. Hologic left one of these cameras here. I can use it. You can see there the device is like a cylinder with a window on the side, aspirates the pathology, the polyp or the fibroid, and there is a blade moving back and forth and cut into the fibroid or polyp and remove it. Same thing as endometrial ablation. It's a quick procedure, very efficient and very quick, speedy recovery. Patients would go home 1 or 2 hours after the surgery, full recovery in 1 or 2 days. These procedures, mostly we do them in Denver. Myomectomies, meaning removal of the fibroids, that can be done hysteroscopically, or in Denver we do them laparoscopically with a robot. Radiofrequency ablation for fibroids, we do it in Denver only in Denver at this time, or hysterectomy. Pretty much over 90% of hysterectomies are done robotically. The patient will spend the night in the hospital, go home the next day. Full recovery will take 1 to 2 weeks. There are only 4 or 5 small incisions in the abdomen, and recovery is quick as well. This laparoscopic radiofrequency ablation for fibroids, I think, is a procedure that I can do here in Burlington at Kit Carson Memorial Hospital. It's a laparoscopic procedure, so the patient goes under general anesthesia. We make a small incision to have a camera for laparoscopy. Then another small incision for an intraoperative ultrasound probe. First step is to do something called mapping, and using the ultrasound, we need to figure it out how many fibroids are there, where are they located, how big they are. And then percutaneously through the abdominal wall, we insert a needle. That needle is guided under ultrasound guidance into the fibroid, and then it deploys another 7 needles that will release the energy. The radiofrequency energy will bring the temperature in the fibroid to 100 degrees Celsius, and the tissue will be transformed into a mass of proteins, will not have any metabolism, no viability. The fibroids will shrink, will not go away, but they don't grow, and they don't cause any problems like pain or bleeding any longer. Destruction of these fibroids is called coagulative necrosis, and that process doesn't hurt, as opposed to ischemic necrosis, when we shut down the blood supply into an organ or into a fibroid. That ischemic necrosis hurts for days or even weeks. I think this is a very safe procedure. The risks associated for complications are minimal. It's just the laparoscopy part. Everything is done under direct visualization. I started to do this procedure in Denver a little over 2 years ago. Results are excellent. I think it's very good for patients that have 1 or 2 fibroids and they don't want to go through big surgery to have the fibroids removed or have a hysterectomy. This way, if we do the ablation, the fibroids will not grow, they will shrink, symptoms will get much better, and recovery is much, much faster. This procedure is called CESA, laparoscopic radiofrequency ablation. So hopefully we'll be able to start doing these procedures here. This is how it works. Again, we placed the laparoscope, the ultrasound probe Yeah, so first image, prep and assess the cavity and the fibroid. Second, visualize, deploy the needle into the fibroid on number 3, and then deliver the energy. Having the advantage of this ultrasound guidance, we make sure that we ablate the fibroid entirely. As you can see in number 4, that whitish area is the area that will be ablated with one deployment. Then we pull the needle back and reinsert it into the other area so we can ablate the entire fibroid. Below, you can see an example of what happens with a fibroid that's like baseball size and consistency and turn into a marshmallow. On the right side, you can see actually the operating room. So we have 2 screens. On the left, we see the images from the laparoscope. On the right, the images from the ultrasound. That's the setup in the OR. On the left screen, you see the ultrasound probe and the needle going into the fibroid. On the right side, you see the other screen, and you see a yellow circle that will show us the area that will be ablated. So this way we know what's left and make sure that we ablate everything. Same images. Next, again, we talk about robotic surgery, either myomectomy, removal of the fibroids, hysterectomy, or combined cases, and these procedures have to be done in Denver. And I'll be open for questions. Do you have anything, Jenny, to add?
I would just say that while many women think that they require a hysterectomy once they reach a certain age, or their mom had it, or their sister, or their grandmom had it, that we're really lucky in this community that we have more minimally invasive options, and so these are the options that Dr. DeBella went through that are available to you in this community, and some of the smaller communities around the country don't have always the option for some of these minimally invasive treatments, and they're directly to treat your symptoms. So if something is hurting or if something isn't feeling right, talk to your provider, and your providers are educated on what we've been talking about today as well, so they'll know what you're talking about. If you say what your symptoms are there other ways rather than just a larger surgery to be able to help me with my symptoms? And just to be clear, Dr. DeBella, some women don't know what a hysterectomy is. Can you just say a little bit about what a hysterectomy is? What are you removing, and what the effects of that are?
And call the office in Denver directly. It's much easier though to be seen here. So this way we avoid somebody driving all the way to Denver. We establish that there is nothing concerning and the patient will drive back home. So it's easier to be seen here for these reasons.
So a follow-up question is, then do you talk to my local doctor? If I'm having a problem, do you tell them that,
yes,
that you're seeing me? And so the local doctors know that I'm seeing you and there's communication?
Yes, there is, and we always fax back. We talk on the phone, and then to make it even more efficient, I also have access now to everything that's done here at the hospital, blood work, imaging, or consults in the clinic.
So we don't have to go get our records and have them sent to you. You can, oh, that's wonderful.
Yes. Yes.
That's great.
I have a question.
Yes.
I know a lot of women, younger women, suffer from infertility. Is that something that you deal with?
The first basic steps, yes. So we can do investigations for the patient, for women. In general, infertility, we call it after 1 year of trying unsuccessfully to get pregnant. 1/3 of the cases there is a problem with a female, with a woman. 1/3 of the cases is the man's problem. 1/3 we don't know. Everything turns out normal with a woman, with a man, but they cannot get pregnant. So we do the first imaging, blood work. If something needs to be corrected anatomically, like a big polyp, a big fibroid, we can do that. Endometriosis, take care of that. For men, we send the patients to Denver to do a sperm analysis, and then if everything looks good, the first steps we can do it here as well, do Clomid. Clomid is a medication for ovulation induction, 5 pills that will be taken day 5 through day 9, and usually we do 3 cycles of Clomid. If that fails, then the next step for the patient is to go to reproductive endocrinologist in Denver. If there is a cause for infertility, like endometriosis, adhesions, something like that, then surgically we can address that.
And what do you consider high risk for OB?
Pretty much, in general, is everything that's outside of the normal pregnancy. So now we call normal pregnancy low risk because there is still a risk for problems. High risk could be anything like gestational diabetes, gestational hypertension, preeclampsia, or pre-existing conditions like uterine anomalies, chronic hypertension, history of blood clots, thrombophilia, other conditions.
And if I had a C-section prior, would you still be able to see me if I wanted to deliver normally? How would that work?
So we do the consults, that's called vaginal birth after cesarean, VBAC. We do those in Denver. In general, it works very well. It's a little bit of struggle sometimes because we don't really want to do inductions with VBACs. So it's better to wait until labor will start, but the distance is quite long, so sometimes we do have to bring patients for inductions. For induction, for a VBAC, then either we use a transcervical balloon catheter or Pitocin. The hospitals that are allowed to do VBACs have to have an obstetrician on the deck in the hospital 24/7 and an anesthesiologist. The main reason is because the most severe complication, possible complication, is uterine rupture. If that happens, we see that based on clinical symptoms and on the monitor, but you have to be able to start and deliver that baby in probably 5-6 minutes. So we have our own patients admitted at the hospital in Denver. We do have an obstetrician there all the time. If there is a problem, he or she will take over until we arrive at the hospital. Occasionally we do this in patients with a history of 2 C-sections as well.
I'm a first-time mom and I am worried that I am in labor, but I'm not 100% sure. Would you recommend for me to go to my local PCP or the ER first?
Yes, for sure.
Okay.
It's not easy to handle it, so it's not easy to handle it over the phone like myself or somebody else will call. So the safest is to show up here. And there is the option of monitoring, do a cervical exam, and then make a decision. And I think it's also better to evaluate the level of urgency. Like, yes, somebody may be in labor, but there is no concern. You can drive yourself to Denver versus there is an imminent delivery. Then we need an ambulance or a flight. Or, sometimes it may happen that here in the emergency room, they may need to assist for a delivery. And they all have done that, so they will cover. those physicians. But yes, I think the first step is either call the clinic here or go to the ED to be evaluated, and then we'll make a plan.
Dr. DeBella, one last question. Talk to us old women about hormone replacement.
So hormonal replacement addresses issues related to menopause. Somewhere between 48 and 52, the ovaries will stop producing estrogen and progesterone and testosterone. Ovaries secrete testosterone as well, so women before menopause, they have a level of testosterone in their blood as well. Symptoms related to lack of estrogen are hot flashes, night sweats, insomnia, moodiness, vaginal dryness, and painful sex. In time, also lack of estrogen can lead to osteoporosis. So to prevent osteoporosis or alleviate those symptoms, women can take estrogen. If somebody takes estrogen, we need to give those patients progesterone as well, because otherwise the lining inside the uterus will keep growing and turn into hyperplasia and possibly cancer. Progesterone also helps with sleeping, so we recommend to take it at night. Some women choose to do testosterone as well. That helps with the level of energy, focus, and sexual functions. So it depends on what those patients are looking at to improve in this. Estrogen and progesterone is covered usually by insurances. Testosterone is not, so they need to go to one of the clinics here for pellets. Providers here will check the levels, adjust the levels accordingly to what's needed. I am very much in favor of hormonal replacement therapy. There were issues in the past. We thought that estrogen can cause cancer. We know at this time that estrogen doesn't cause a cancer, and mostly the main scare was about breast cancer. It is true that if somebody develops a breast cancer and that breast cancer has estrogen receptors, that tumor will grow a little faster if that patient takes estrogen. But on the other hand, the outcome is not worse, let's say, if the patient was not on estrogen. So same stage breast cancer, women taking estrogen versus those not taking estrogen, they have the same outcome with the same treatment. Is the same thing for testosterone. I also know from urology that even in patients with prostate cancer now these days, after surgery and removal of the prostate, the urologist will allow management with testosterone if there is a need.
Just a follow-up question to that, Dr. DeBella. If a woman didn't know that they could be on hormones and they're postmenopausal and they have some of the symptoms that you described, would they be alleviated if they started on hormone replacement therapy if they hadn't for several years after menopause?
Yes, so it still works. The other thing is, when you start taking hormone replacement, you can stop it or lower the dose and see how you feel. And if you go back, let's say you stop it after a year or 2 or 5 and see how you feel, and symptoms are significant, that patient wants to go back on hormones, they will work the same. So there is no risk that if you stop and restart, there is no risk that it's not going to work. So they will work the same. And the dose basically is adjusted mostly depending on the symptoms. Going up, stay the same, go down a little bit.
Well, anyone else?
Thank you so much, Dr. DeBella.
Thank you.
Thank you.